Welcome back to Mental Health in Our Community, y'all. And I'm super excited about this episode because it is so necessary. It is so critical, but it comes with a lot of baggage. And what is it? You may be asking. That is medication as an intervention for our mental health symptoms. So often when I'm sitting across from clients and I get to the place of diagnosis and treatment recommendations, and I'm saying, you know what? I think medication is an intervention for balance. It is met with a mixed bag. And I understand where that mixed bag comes from. When it comes to medication for us in our community, it is not just so straightforward. For a lot of people, medication feels like, yeah, it's the easy answer. But when it comes to our community, there's been so much mistreatment, there's been so much misinformation, there's been a lack of modeling, there's been so much malfeasance, right? That it makes it more challenging for us to lean into a solution that feels like an obvious pick for a lot of people. So myself and Dr. Brian Dixon, we understand that. We see this up close and personal. We've experienced the ways in which the medical and psychology industry has discriminated against, mishandled our community in ways that prevent us from seeking the care and ultimately leads to our suffering. So we sit down to address those things, and then we lean into medication as an equalizer, as a balancing act for the mental health symptoms and conditions that we experience. So y'all sit down, y'all take a listen and tune in. We're back for another episode of Mental Health in Our Community, and I'm very excited to be joined with Dr. Brian Dixon, who is going to be talking with us about psychiatry and psychology and how that mix comes together for us. So could you please introduce yourself? Let us know who you are. Where'd you, in the world of misinformation and disinformation, please tell us where you got your credentials from, where you're licensed from, all the good stuff.
Excellent. Well, thank you, Dr. Hill, for having me on. And I love making sure that I share the importance and the awesomeness of psychiatry with as many people as possible. I'm originally from Texas, a small town called Lufkin, Texas. That nobody is,
Lufkin, you know
yeah,
Lufkin?
yeah, I'm from Lufkin, Texas. Yes.
Lufkin is.
I love it. Yep. Go Panthers. Finished high school there.
Yeah.
Went to college at Baylor in
Oh,
Waco, Texas, and
okay.
then I got into the medical school at the Texas A&M College of Medicine in College Station.
Mm.
And
Oh, okay.
yeah, so did that for 4 years, and then I went to residency at the University of Kentucky in Lexington, Kentucky.
Whoa, I
Yeah.
did my residency internship at Federal Medical Center in Lexington.
Oh, really? Oh my
Yeah.
God, I didn't know that.
Yeah,
Oh,
yeah,
and
yeah.
Lexington is beautiful. Oh
Lexington
my
is
God.
beautiful. It's very,
Yeah.
very green, very serene, all the
Yeah.
things.
Yeah, it's incredible. And then and after I finished all that training, so 4 years of college, 4 years of med school, 5 years of training in
Okay.
psychiatry, and then I came back to Texas to practice, and now I'm in Fort Worth. I run a private
Mhm.
practice where I do direct pay psychiatry with people of all ages, all backgrounds. Running a company and doing the do. So yeah, it's 200 over 200 and something $1,000 of education, 13 years. So I know what I'm talking
Yes.
about.
I
Okay.
feel like we need to say that. Like people, I wanted to pause to say this because I feel like in the world of influencers, in the world of wellness gurus, of coaches, people don't understand the rigor and the time commitment it takes to be a certified licensed psychiatrist and psychologist. And I like to lay that out. Like that's what, 11 years for you or 12? Did I miscount?
Uh, yeah, so all total 13. So,
13.
mhm.
13 for Brian, Dr. Brian Dixon, 11 over here, similar. So I will introduce
Mhm.
myself again for those of you who may be new to the channel. Dr. LaWanda Hill, licensed psychologist. I did 4 years of undergrad at Southern. We have similar backgrounds in the sense that we come from these like small rural towns and did our training in these small areas and then branched out. So I did 4 years at Southern University A&M College in Baton Rouge, Louisiana. Then I did my 2 years master's at University of Houston, and then it was a terminal master's. Then I did my 5 year doctorate at University of Houston, 1 year of internship, which will be equivalent to your residency at the at Federal Medical Center in Lexington, which I did not know we had shared time in Lexington. And then my postdoc, I came back to Houston and did my 2 year postdoc, and then I left and have been in California ever since. Doing the thing. So 11 years between the two of us, there's 20 some, there's a decade of training.
Yep.
So I think that we are, certified to talk about this topic and really, address all the things. So thank you so much for being here, Dr. Dixon. I'm excited to get into it. Thank you for introducing yourself to the community. I wanted to start off with talking about this series. As you know, I've been talking about mental health in our community.
Mhm.
And I wanted to start with, as it relates to this topic, because psychiatry equals medication, and medication for the Black community in particular can come with a lot of historical trauma, misinformation, lack of access, lack of modeling. And I just wanted to kind of just name that before we go into the solutions, because you and I both know what happens when you have ethical, competent, culturally sensitive psychiatrists and psychologists on your team, but we also know that there's a lot of barriers to overcome to get to that. So, from your opinion, and I know you see everyone, of all race, gender, age, and all the things, but what has been specifically the Black community? What have you seen in your practice that has been a barrier for us
And I'm
to?
gonna say suffering and also suspicion. And so what I see
Ooh,
with a
suffering and
lot of
suspicion.
what I see with
Mm,
a lot of my Black patients who come in is they are suspicious of what's going on. Number one, they don't know that that we exist, right? They come in and they go,
right.
"Wait, it's
Yeah,
this
they
is you?"
kind
And you go, "Yeah, it's
of.
me." And then
Yeah.
they go, "Well, this is what I've heard, or this is what I've seen because this bad thing happened to my aunt, or this bad
Mm,
thing happened to my cousin, and so I'm very leery about what's going on." Or worse, are you just gonna drug me up and make me
mm.
not feel? And I'm like, "Y'all, no,
Mhm,
that's
mhm.
not how I roll."
Let's go back to Tuskegee experiment.
Yep.
Forced sterilizations,
Mhm.
lack of culturally competent care, overly diagnosing schizophrenia, sedating people. All of these things live in the community, y'all. And so I wanted to take the time to say, I get it. I understand the suspicion that comes in the room in the sense that you've heard of someone who's been overly sedated. You've heard of us being mishandled. You've heard of us being guinea pigs without consent, unbeknownst to us. So you've heard of all these things, and so that unfortunately doesn't go away because you have a 45-minute psychiatry appointment. It comes with you in the room. And so I feel like that is important to acknowledge and normalize. Have you had any people specifically, Dr. Dixon, to just name like, I don't know if this is because I've had clients say to me when I've referred them to psychiatry, I don't want to get addicted. These are the words that they use. I want to use clients' language. I don't want to get addicted. I feel like I should be stronger than that. I don't want to be weak. I feel like my faith is good enough. Like these are all of the myths and misinformation and the cultural messaging that comes in the room. And so for you, have you heard that in the room? And what's your response to some of it?
Yeah, all of that and more. I mean, I've heard every variation under the theme. I've heard, yes, you're going to over medicate me.
Mhm,
You're not going to listen to me. So that's one I
mhm,
probably get across the board is I'm only going to be in here for 5 to 10 minutes, and you're just going to give me a prescription, and then I'm going to leave.
mhm,
And what the very first thing I do is the very first thing that you do, which is validate, right? So
mhm,
I make sure that they feel heard and seen. I recognize that, hey, yeah, all this bad stuff has happened, but
mhm,
I'm different, and I'm gonna
mhm,
spend the time to listen to you, and then we're
mhm,
gonna put the plan together, to literally together. Like it's we're not. I'm not one of those paternalistic doctors because I'm not sitting in your shoes. You get to make
mm,
the decision. I get to be your expert on the side that walks with you while you get to feeling better. And so
mhm,
that's to me is the power of the rapport. That's the power of
mm,
validation, the power of the rapport.
mhm.
And it's so fun. So that by the end of the session, what happens with a lot of my Black clients and my white ones too is they go, "Oh my gosh, that wasn't as painful as I thought it was going to be, and you actually listened to me."
So
Because
I just really want to pause here and talk about how much we normalize suffering in our community, y'all. We normalize like letting things get really, really bad. We don't always do the preventative work that we need to. And this is not shaming. I just want to name it because a lot of people who are watching and listening is like, yeah, that's me. It doesn't have to be this way. We have a number of reasons why it gets this way, but it doesn't have to get this way. We could be in a place where the moment we feel some level of discomfort, I'm like, oh, my pinky hurt. I need to call my PCP.
yeah,
Okay. That should be where we are, but we're not there. And I think before we even start talking about solutions, it's important to name that. So, with your clients in particular, Dr. Dixon, do you find that or what percentage maybe of your clients do you feel like are at the what we would call early onset, like they're just starting to experience some discomfort? How many of them have been kind of in the throes of it for a little bit? And how many of them have been like suffering for a while?
Oh my gosh. Dr. Hill, and I know this is going to sound unfair, but I'd say 90% are
Mm.
in stage four. Like they're not coming for
Wow.
preventative. They're
Wow.
coming because something bad has happened.
Similarly, I've sat with, and like you said, we've been trained to absorb years and years and years of trauma, years and years and years of pain, years and years and years of suffering. And so if that's you, okay, I hope that this episode is the episode that'll make you be like, okay, you're in good company. There are a lot of people who wait to this place, but don't wait another day. Don't wait another day. For those of you who are
Amen.
not at this place, who you have not been suffering and you feel like, it's been kind of uncomfortable for a while, let this be your motivation to move forward. Because yes, we are prepared, we are trained to treat it, but you do not have to continue to suffer because a large part of what we're trying to combat is the suffering and getting beyond the barriers. You've overcome those things, you're motivated, and now you want to tap into the help, which is psychiatry and psychology. So Dr. Dixon, give us general psychiatry 101. 101. What is general psychiatry 101? Give it to us. Let us know what it is for the people in terms of solutions for mental health.
Well, again, thank you for this time and this opportunity. I'm going to couch it like this. So, psychiatry 101, I'm going to tell you that to have good psychiatry 101 is three different legs on the stool. So, the first leg is behaviors, being very thoughtful about what behaviors you're doing, behaviors with eating, behaviors with
Mhm.
exercise, behavior with sleep, and then behavioral triggers, because there are triggers that set us off and make us do things without thinking about it. And so,
Mm.
anytime I'm working with any of the adults that I see, including any of your awesome listeners, hopefully y'all will hit me up. We start there. We don't start with medicines. I'm going to talk medicine stuff
Mm.
briefly in just a little bit, but the first third of your plan is all behavioral stuff, being aware of
Mm.
your exercise, how much you're exercising, tracking your exercise, and being aware of food, being aware of sleep, that sort of thing. And then the second third of your plan, the other leg of your plan is the psychological side of things. It's that,
Mm.
yeah, it's the therapy part. It is, I always tell people you are a terrible therapist for yourself because you're too close to yourself to be able to see things.
Mm.
And so having a third party that's trusted and trained is
Mm.
incredibly important. And so the after you do the behavior part, that's the first third. You do the therapy part, that's your second third. That means
Okay.
66% of your psychiatry plan ain't got nothing to do with medicines.
Mm.
Okay. So
66 of your psychiatry plan has nothing to do with medicine. I got to circle back to that, but keep going.
mhm, okay, and then that last third is that's where the medicine part comes in. So you need to get someone who is experienced and trained to use
Okay.
medicines responsibly. Those medicines treat symptoms, so they're not magic
Mm.
pills. They won't make you happy.
Mm.
They won't solve your relationship crises. They
Mm.
will not fix racism at work. What they do is that they address specific symptoms. So
That's
symptoms like
good, Dr. Dixon.
anxiety,
Mm.
yeah, symptoms like depression, symptoms of excessive worry, for
Mm.
attention, for seeing things and hearing things, stuff like that. So that's what those medicines do. And there's lots of them. And the key is you need a trained person to make sure that they're
Mhm.
watching, that they prescribe them appropriately. And then when something
Mm.
bad happens, because sometimes you have side effects, because every medicine has a side effect, you want to make sure that you can make quick adjustments so that things don't get worse, because that will reinforce the that stigma and difficulty with psychiatry. So
Psychiatry, as a psychiatrist, is a comprehensive lens, and that's
yes,
three parts. And the first part is behavioral, the second part is psychological, the third part is psychiatry, medicine.
the
And so
medicine.
you are approaching this when clients come to you with whatever degree of pain or suffering or symptomatology, is to say, what is your behaviors first? What is your psychology second? And what meds do you need to support that? I think that that's big because I don't think that often people, at least the clients that I have, did some motivational interviewing to help them get through their challenges to get to psychiatry, often think that that's the approach. They believe that they're trying to give them medication 100% of the treatment plan.
Mhm.
Wait,
Well,
how about psychiatry as a solution? When we're talking about mental health symptoms and psychiatry and where it comes in as a solution, how would you describe psychology as a psychiatry, I'm sorry, as a solution? For me, when I'm thinking about psychology as a solution, I talk to clients about both what is deeply embedded, meaning
mhm,
things that you've been hearing, seeing, feeling, experiencing, internalized as a kid is more deeply embedded. And what psychology helps you do is peel back those layers and get to the origin. And sometimes even sow new seeds because you need to shift and transition. And that doesn't always require medication, right?
Mhm.
Because it's more of a nurture kind of argument, right? A nature and nurture in the sense that you may be vulnerable to certain types of challenges because of where you live and how you grew up and what kinds of resources you had access to. But what therapy does is kind of help you within your own agency peel back those layers and develop new solutions. Now, when I introduce psychiatry, to your point, we're talking more about some biological origins, right? That means part of what you experience in your mood and your thought and your behavior and your responses can feel like it has a biological basis in part. Would you agree or disagree with that?
100% agree. Yep.
Okay.
And yeah, taking that biological aspect and tying it into psychology therapy as well. Yeah. So a biological medicines and interventions to help you feel better and
Mm,
ideally improve your specific circumstance. And I want to
mhm,
be very clear about this. It is not a fix all cure all.
mm.
It is to address a particular circumstance
Okay.
so that then you can go and function in whatever domain you need to, whatever
Okay.
setting you need to.
All right. So then suffice it to say, correct me if I'm wrong, psychiatry provides a level of support that can help you on a biological level. So I want to talk about medicine in general. When you talk about medicine and psychiatry, I know that's a big bad M word for a lot of people. But medicine, maybe at its most fundamental definition for you, Dr. Dixon, it does what? What does medicine do at its fundamental definition?
Yeah, the goal of good medicine is to bring a balance, to rebalance in
I
such a
like that.
yeah,
I like that.
yeah, rebalance in such a way that you can have optimal functioning, that you can do what
Mm,
you need and are called to do. So let me give
mm,
you an example.
okay.
There are medicines that can help with sleep, and there's lots of different ways that you can do it. But the medicine helps with sleep, so that then you can get enough sleep to start to feel better. So and kind of get back to some kind of balance and baseline, right? So yeah, so the ultimate goal is not to fix everything; it's to help you get back
With
into a
balance.
routine and balance to
Good.
fix
That's so
yourself.
good. That's so good. So you're giving me language. It's so good to have a psychiatrist here, y'all, because you say these things and you like, I'm pretty right on this, but you have validated it. I often tell clients that we want them to be at equilibrium, homeostasis,
Oh, yeah,
right?
yeah. Mhm.
We want them to be at homeostasis. And for a lot of us, homeostasis is here. Now, life will make you kind of go up or down, oh my God, my Eagles just won. I'm up, Last week, my Eagles lost 2 weeks in a row. I'm kind of down. You know what I mean? But that's like your normal, typical day to day. When we're starting to talk clinical,
Mhm,
right? Which to me, and intersect and correct me if I'm wrong at any point, we're talking about we're off balance.
mhm,
And so when we've done the basics, the sleep, the exercise, the behaviors, and then we've done the psychology and we're talking mindset, we're talking habits, we're talking beliefs, and now we're still off balance. To me, that's when psychiatry comes in because now whatever it is off balance, and we're going to run through the different types of medications that helps us balance.
mm,
Now you need a little bit more support. And I always use the example I have sinus disease. So it doesn't matter how much I love outside. Outside don't love me.
yeah.
Okay. So when I go outside, y'all, I am subject to a lot of mucus and a lot of eyes watering, itching. I'm off balance. And what helps balance me is Zyrtec. Right. And I think we think about physical balancing in a way that feels less threatening, but when we think about mental health medications to balance, it feels more personal. It feels like it's harder for us to get there. So I often like to use those physical examples to help people understand. So when we're talking about balancing, we have
Mhm.
categories. We have SSRIs, we have psychotropics. We I want to talk those two. So can you give us some understanding of the difference between SSRIs and psychotropics to help balance and what kinds of conditions do they treat?
Yeah, gotcha. Well, even before I do that, I'm going to throw out an analogy that I use
Okay.
for medicines, kind of any medicine. So I want your listeners to think of whatever highway, interstate highway they hate the most. So
Mm.
I'm in Texas, and I-35 is terrible. I-35 is like the worst highway ever. It's kind of like Highway 6 in Houston, or
Okay.
yeah, you
Oh,
name it.
wow.
Yeah,
Ugh.
like it's super bad.
Congested,
Yep.
always, no pathways. Got it.
Correct. So that is dysfunction. That is you being
Mm.
unbalanced, right? That's too many people moving to the area. They didn't build up the infrastructure, blah, 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 blah. Well, how do you get that to improve? Well, because you can't shut the highway down. In other words, I can't put you away somewhere and pump things into you. So how do we get the highway to improve? Well, you call in experts, you call in engineers, you call
Mm.
in all of these folks, and over the course of 6 months, a year, 2 years, whatever it takes, you gradually add a HOV lane, you add a
Mm.
street line, you
Mm.
add another lane, you do all these different things, and then at some point, you take all that stuff away, and ideally, the traffic is flowing and everybody's happy again. Okay,
Mm.
so that's the
Mm.
theory of how I want medicines to work. So I'm gonna bridge you from one place to
Mm.
another.
Okay.
Ideally, I don't want you on anything forever.
Wow.
The goal
Okay.
is to make a bridge. Now, in
That's good.
some cases, the bridge has to extend for a really long time, but
Mm.
yeah. So with that analogy
That's
now in
good.
mind,
That's good.
yeah, yeah. Um, let's talk categories. So yes, there are different categories. So SSRI stands for selective serotonin reuptake inhibitor, and it's based on a theory. And y'all, a theory is a guess. So let me take the other disclaimer. Dr. Hill is not Jesus, nor am I. I can't. I don't read minds. I'm not God. I'm not omnipresent. I'm
Not
not all
at all.
powerful. Okay. Yeah. So the theory of a certain type of diagnosis, a certain label, is that it's related to serotonin. And if
Yeah.
you block serotonin for certain brain cells, it makes serotonin more available for other brain cells to pick it up
Mhm.
and use it over the course of time.
Mhm.
And so,
And serotonin is notable for mood, right?
correct. So serotonin is related to mood, is related to anxiety and worry.
Okay.
It is the kind of go-to medicine for anybody with generalized anxiety disorder. So the
Mhm.
most commonly diagnosed label in our society is generalized anxiety
Mhm.
disorder.
Mhm.
And you can Google all the symptoms because it's on the Googler. It's on
And
there.
you ain't even gotta go because we got an episode dedicated to
Oh,
it right here, okay?
yes, yes, exactly, and you're getting expert, care. Yeah, none of that nonsense is online.
Right.
Generalized anxiety disorder, it's also great for major depressive disorder, so if you've ever
Absolutely.
heard
We just covered.
MDD. Mhm.
Mhm.
We use it for PTSD, which stands for post-traumatic stress disorder. If you have OCD, which is obsessive compulsive disorder, you'll be on most times you'll be on an SSRI at a really high level,
Mhm.
and that's very purposeful because that's what the data shows works.
Mhm.
Yeah, any type of trauma, trying to think any of the, panic disorder. Yeah, so that's what SSRIs are very good at. They get a bad rap because there are, depending on your age and situation, there are times when blocking serotonin can lead to sometimes worsening mood, which is not
Low
supposed to.
sex drive.
Yep, it can have low libido. Yep, low sex
Mhm.
drive, erectile dysfunction.
Mhm.
Some folks will have bad thoughts, like suicidal thoughts. Again, not very common, but that is a side effect. And then if you have an undiagnosed or undertreated bipolar disorder,
Mm.
there's a risk that you can worsen someone's mania, which is where you have these big
Mm.
grandiose thoughts and you're staying up for 4 and 5 days at a time and stuff like that.
Mhm.
But SSRIs are generally very, very safe. They're very effective. They're very inexpensive. And then, like I
Mm.
said, the goal is to get off of them at some point. But in general,
Mhm.
there's like 5 or 6 that are pretty equivocal, which is a fancy doctor term for. They basically all work the
The
same
same.
and in the
Okay.
same way. Mhm. If you've ever heard of a benzodiazepine, so
Mm.
benzodiazepines are like Xanax, Klonopin, um, oh my gosh, Valium.
Mhm.
Those work on GABA,
Okay.
so it's a different mechanism. The good thing about benzodiazepines is that you can use them to break panic attacks really quickly.
Mhm, mhm.
You can use them like if you get on an airplane and you're like freaking out, you can take it and it'll knock that right out.
Benzos are like more sedating, right?
Correct, and so
Mhm.
that's the
And more
danger.
habit forming.
Oh, a million percent. And so as a result, what sometimes will happen is I will, if a person comes in, so is, and again, so let's just take an example of a Black woman in corporate life.
Mhm.
They come in, they finally come into my office. They've already been beaten down and written up at work because the work is a hostile workplace basically for every Black woman, right?
Mm,
When they come in, my goal as a psychiatrist in that moment is to validate, give us a space, and to eventually start to build that plan. But that person is still suffering at the end of that hour. Okay.
mm,
If I decide to start a serotonin based medicine, it ain't going to start working for 3 to 4 weeks. So then what
mhm,
is she going to do for the
mhm,
3 weeks that it takes
mhm,
for the serotonin medicine to kick in? Well, I'll
mhm.
use a GABA based medicine.
It's kinda
Mhm.
immediate.
Correct, to
Okay.
immediately help them with, anxiety, with excessive worry, help them fall asleep, all sorts of stuff
Mhm,
because they can be very helpful, but I always give that disclaimer, anytime you
mhm,
do anything with GABA, like those benzodiazepines, yes, they can be habit forming because they work so well. They're not
mhm,
dangerous medicines. In
mhm,
fact, they build that psychological dependence because you'll take it and they
mhm,
work so fast, you'll go, "Holy moly, this is
mhm,
actually awesome." Well,
mhm.
there
And it
therein
takes you
lies
away from that other 66%, right? That behavior that
correct.
you need to be working on, that
Uh,
psychology you need to be working on. You overfixate on the medicines, which I think this kind of gets into the myths, y'all. It's not that the medication in and of themselves are problematic. It's when you do not have a well-rounded, comprehensive plan. And that's
100%.
that's on you. That is
Yeah.
on us to make the recommendation and for you to follow through with that.
100%. Yep.
Okay.
Mhm. Yeah,
Okay.
and so you can actually use those medicines at the same time. The key is
Okay.
make sure that you're doing it responsibly and know all of the side effects. And so they say
Yes.
psychotropic is antipsychotic medicine.
Okay.
Mhm.
Okay.
And
Okay.
so what most doctors mean when they say antipsychotic. So
I see.
yeah, we had talked earlier about serotonin. We had talked about GABA. There's another brain chemical that's very common called dopamine, which everybody's heard of, right?
Mhm.
It's your happy chemical. It's also related to your mood.
Mhm.
It's related to
The
attention.
movement.
Yeah, and yep, and it's also related to movement, correct.
Mhm.
And so the theory of dopamine is that if you have too much dopamine running around at all the wrong times, you can start to hallucinate. You can literally see things.
Mm,
And we call that psychosis if you see and
mhm.
hear things that aren't there. And so they develop medicines to block
Good
dopamine in
job,
certain
Dr.
parts of your
Dixon.
brain.
I love
Yeah.
that. Yes,
Yeah.
yes, yes, yes.
Yeah.
Continue,
Yeah.
continue.
Yeah, and so they call those antipsychotics, right? So, meaning
Antipsychotic.
antipsychosis, so I
Okay.
block dopamine, yep. And so those are they're very safe medicines for what they are used for. Most times, so for like, you had mentioned schizophrenia early in the show.
Uh-huh.
Schizophrenia is a dopamine, theorized, issue. So in other words, folks with schizophrenia have way too much dopamine flying around, and so you can use antipsychotics for that.
Mm,
The theory of bipolar is that there is a dopamine component to bipolar, especially with that
okay.
mania stuff,
Okay.
and so a lot of people will use antipsychotics in bipolar treatment. Antipsychotics can also be used for aggression and agitation. So
Mm,
for a lot of my kids with my adults who have an intellectual disability, if they get
mm,
agitated, I'll use
mm.
it for them, and then
Okay.
for kids that are screaming and yelling and acting fools, sometimes you can help them with their agitation as well. So
Okay.
yeah, and so dopamine, you're correct. It is related. Dopamine helps your nerves talk to your muscles. So if
Mm.
I block too much dopamine, it'll look like you have Parkinson's. You'll get the pill rolling
Uh-huh.
tremor.
Uh-huh. Uh-huh.
Yeah,
Uh-huh.
and so yeah, so as a result, we have to be really careful with those medicines. Again, they are very safe when used appropriately and in the context of the
Mhm.
whole thing. So
Mhm.
so those are antipsychotics. if you've ever heard of like Abilify or Seroquel or Risperdal, Haldol, Thorazine, those are all
Those are the
antipsychotics.
antipsychotics. Okay. So what I would like for us to kind of close out with is for you common SSRIs that treat anxiety and depression, generalized anxiety and major depressive disorder, and then common antipsychotics that treat, schizophrenia or schizoaffective and or are used to treat the mania part of bipolar. If you could give us those
Yeah.
categories in that way for people, that would be awesome.
Yeah. So every medicine in the United States has generally two different names. There's the generic name, which is the literal chemical name, and then there's the brand
I
name,
was
which
gonna say,
is
why is that? It's
yeah.
because it's like sciences versus like,
mm,
okay.
it's always about the money, Dr. Hill. Come on now.
Okay. My friend
Somebody.
was like, "Yeah, but I'm on the generic." I'm like, "Why don't they just label it this?" I gotta ask him that. But okay,
Yeah,
that makes
that's
sense.
it. Yeah, it's a whole thing. We'll have to have another hour on that. So yeah, so when it comes to serotonin-based medicine, there's kind of the big five. So
Okay.
the one that I'm prescribed the most serotonin blocker is called fluoxetine,
Mhm.
Fluoxetine, fluoxetine, also known as Prozac.
Mhm.
Next most common is sertraline,
Mhm.
Sertraline, sertraline, which is Zoloft. And then
Mhm.
there's a couple other ones, Celexa, which is citalopram, Lexapro, which is escitalopram, and then Paxil, which is paroxetine. So those are
Mhm.
kind of the big five. They've been around forever.
Okay.
Again, really safe, not very expensive. At the end of the day, I use them literally all the time, and kids down to the age of like 4 all the way, and my oldest patient is like 72. So they're very universal, very helpful.
Okay.
When it comes to the antipsychotics, it all depends on what your working diagnosis is, your label is. But
Mm.
I'd say probably the most common one I can think of right now is Risperdal, also known as
Yeah.
risperidone.
Mm.
And then the next common would be Abilify, which is also known as aripiprazole. And
Mm.
then there's Seroquel, which is quetiapine with the Quetiapine, quetiapine. And then there is Zyprexa, which is olanzapine. And then, like I said, there's some older ones like Haldol, which is haloperidol, chlorpromazine, which is also
That
used.
hell dog I experienced mostly when I worked in the prison system in Lexington when they were like active psychosis, actively agitated. Like it just brought the psychosis to like a screeching halt.
Yes, which
That's
is
what Haldol did.
yes, and it's a blessing and a curse
Yeah.
because when you block dopamine that fast and that strongly, yeah, it curbs the
Mhm.
agitation, but you also run the risk of, if you've ever heard of tardive dyskinesia, it's where you
Uh-huh,
start to
uh-huh,
move and do
uh-huh.
things. Yeah. Mhm.
Yeah.
So there's always a trade-off.
That movement part. It's not getting that movement part.
Correct.
Okay.
It's that movement part. Yep. And one of the hiccups, you had talked about side effects with SSRIs, with the serotonin medicines. One of the hiccups with the antipsychotics, some of them will make you gain weight, period, in the sentence. Like even if
Mhm,
you change your diet, you're exercising, you're doing the rest of the plan, you'll still
mhm,
gain weight. So
mm.
Risperdal, Abilify, and Seroquel, and Zyprexa, they are notorious. So if y'all are
Weight
listening to
gainers.
this, oh yeah, you're listening to
Mm.
this and you're like, look, I'm doing my Pilates, I'm watching what I'm eating and all the things, and I'm still not, I'm still gaining weight. What's wrong with me? Well, it actually may be your medicine, and it is worth talking to your doctor about other
Mm.
alternatives. And if you need to stay on it, stay
And
on
the
it. But
thing
the thing
is
is, right now, just go feel better first, and then we can figure out all of the details when it comes to making sure that we minimize those side effects. So.
now, last question before we figure out where people can find you as it relates to post-traumatic stress disorder and also premenstrual dysphoric disorder, because those are two. So I've covered major depressive disorder, generalized anxiety disorder, post-traumatic stress disorder, premenstrual dysphoric disorder, and postpartum disorders. Suffice it to say, SSRIs could treat all five of those categories.
Correct.
Okay. Okay.
Yeah.
All right.
So right now they're the running, one of the running gold standards for all of those.
Mm,
Here's where, so Dr. Hill, when I mentioned earlier that psychiatrists we do a lot of guessing because
mm,
we're not the rest of the medical realm. We do believe, and I firmly think that there's going to be more and more research and more things coming out to help PMDD
oh, good.
and as women, also with perimenopause and menopause, and the psychiatric and psychological things that go along with those phases of life.
Yeah.
Yeah, so I want everybody to know that we are an evolving field. We don't always get it right in the psychiatry world, but we're going to do our damnness to make sure that we give you safe options as effective as
Mhm.
possible.
That's good. That's good. Yeah, PMDD is, it's been, I've been diagnosed with PMDD in the past for sure. I remember going through my DSM, which is the Diagnostical Statistical Manual of Mental Health Disorders during the throes of the pandemic. And I was just like, I'm pretty sure you've experienced this, or maybe you haven't, but I've experienced this as a doctor of like, these symptoms feel clinical. Let me go pull out my DSM to figure out what is this. I feel like I am existential questioning. My mood is very flat, it's very low, and it's very acute. And going to my psychologist and be like, hey, this is my diagnostical impression. But I'm like what you said earlier, I need somebody who's farther away from it to let me know, and then getting a referral to psychiatry, which ultimately prescribe SSRIs
Mhm.
for me during the PMS period, like 2 weeks pre-menses, because the symptoms subside with the onset
Yep.
of menses, maybe 3 days after. But that was also a high pressured environment at Stanford. And so since then, I haven't had those symptoms. But I know of many clients who are talk to me, and I'm like, it sounds like you have premenstrual dysphoric disorder. And sure enough, they meet the criteria. And I cannot tell you how many clients have been like, I never knew this was a thing, because that's just part of, oh, you just moody, or you just got you know, uh, premenstrual symptoms. It's like, no, there's another level to these premenstrual symptoms, and I have experienced them firsthand. And I hope my clients don't have to, but if you do, don't worry. We got an episode on it, and SSRIs can treat it.
Mhm. Yes,
Okay.
ma'am.
All right. Before we go, I would like for the people to know two things, Dr. Brian. One more question. Why is it that SSRIs are effective with premenstrual dysphoric disorder?
Yeah, that's a great question. You're going to hear us say we don't know a lot, and this is one of those
Okay.
areas. We think it's all tied again to the serotonin
Okay.
theory, and so yes, if you're having anxiety, the theory of anxiety is that there's too much serotonin in certain parts of the brain and not enough in
Yeah.
other areas. So if you block serotonin in those parts of the brain, then other parts can use it. So yeah, so that's the theory. We don't really know why. We
It's a
do
working
also. Yeah, it's a working theory, and as we grow as an industry, as we grow as a specialty, maybe we'll have better answers. But for right
theory.
now, we go, well, it kind of works, so let's just keep doing that.
Yeah, that's what I had. Instance, they were like, "We're gonna give you this and stabilize this mood." It worked.
Yeah,
It
yeah.
worked. I said, no, it worked. I'm not saying it didn't work, but I am more of like, what is the etiology? Like, what's off balance? That's what I wanted to know. Like, what is off balance that's producing these symptoms, and why aren't they consistent? Why don't they happen at certain periods of time? So I am putting this out there for the scientists. Y'all go
Yep.
figure it out, and y'all come back with
Please.
some solutions on why.
Yep. Let us know.
Okay. So you have been super, 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 super helpful, Dr. Dixon. I think it's important, one, to have these kinds of conversations, two, to see faces of people that look like you, that can name our plight, our challenges, and then provide their expertise. So I would like for you to share with the people a little bit about where your practice is located, where you are, and how can they find you, and what kind of clients can you see? Because can you see everybody everywhere, or more of a specific space?
Yeah, great question. So, I am on all the major social media platforms. If
Okay.
you ever just have general stuff, my website is probably the best way to kind of learn about me. So, drbriandixon.com. So, drbriandixon.com. My most active social media, so that's kind of general stuff. If you want to be more specific, I'm on LinkedIn. You can direct message me. My website also has my email, so you can just email me. So those are kind of the general ways of contacting me. If you have non-clinical questions, or if speaking gigs or podcast invites, all that stuff. If you want to become a patient, number one, you'll have to be in Texas, because my
Mm.
license is state restricted. So I'm licensed only in Texas. I'm working on a couple other licenses, but I don't know. I don't know. We'll see what happens with all of that. Because I think I'm officially licensed in Colorado, but I need to follow up on my application. Anyway, so you'll need to be in Texas, and if you're in Texas, I can see you virtually or in person. And then the most beautiful part about, in my opinion, the most beautiful part about being connected in a network with amazing people like Dr. Hill is that even if you can't get to Texas, she's connected to me. So if you're working with Dr. Hill and you
Mhm,
have a medical question and Dr. Hill goes,
mhm,
"Huh, that's a great question." Dr. Hill can text me
mhm,
and I will give her the answer. And then
mhm,
you can say wherever you are, California, Texas, or otherwise.
mhm,
And yeah, because at the end of the day, I don't need everybody in my office. What we need is a better network of Black
mhm.
clinicians who can work together to help people feel better where they are. So yeah.
That's incredible. And I'm licensed in California and Texas.
Oh
So that's a
yeah.
good reminder that, I'm licensed in Texas and there are so many different Texas clients or adjacent, not necessarily my clients, but people who know somebody that I would like gladly refer to you. So that is incredible. Yeah. And to me, that's even more checks and balances for people who are wondering why you're licensed in one state and not the other. You don't have universal license, you have to pass the licensing board for that state.
Mhm.
And having lived in Texas, I had too many clients that I didn't want to give up when I moved to California. So I maintained my Texas license and then I obtained my California license when I moved here. And these are only two states, so I'm not. Maybe not. My clients always push me like, you don't want to get licensed in this state because they be moving and going to different states. I'm like, girl, I'm sorry. I'm not about to take that jurisprudence. I'm sorry, not gonna do it. But
Right.
I will have a strong referral. So it just really is our way of saying that there is rigor. You can't just be out here providing your medical opinion about medications or your psychological opinion about people without having some level of checks and balances. And so I'm grateful to know you, Dr. Dixon. Thank you for breaking this down or it could ever be broke. Thank you for providing your expertise. We got to have you back to kind of dissect some more of the conditions that we've been talking about in general and maybe answer some of the questions that I think a lot of clients have had that I would love to hear from them to hear from you directly. So thank you so much for being with us. Y'all stay tuned as we continue to unpack mental health conditions in our community. More to come.